good afternoon, everyone. Thanks for joining us, our second Doc-Witty CME webinar. Previously was the topic about ONG. Yeah, this time is the second episode from us. So today we have, our topic for today is back pain. That affects almost all of us at this age group. And Dr. Rajandra Kumar Karupiah is going to talk about back pain, young spine versus old spine. Before we start the ball rolling, so let me introduce our doctors today, our speakers today. Dr. Rajandra Kumar Karupiah. He is one of the few consultants that have a double degree in both science and Doctor of Medicine. He pursued and obtained his master in orthopedic surgery in IIUM. He works in numerous government hospitals, inclusive of Hospital Kuala Lumpur, Hospital Tengku Ampuan Afsan, Kuantan, Hospital Sultan Ismail Johor, and in International Islamic University Malaysia Medical Center, IIUM, which is currently renamed as Sultan Ahmad Shah Medical Center. He is now the assistant professor in Department Orthopedic Traumatology and Rehabilitation in IIUM. He joined our hospital, KMI Taman Desa, early this year as a visiting orthopedic and spine surgeon. Without much ado, let's welcome our speaker today, Dr. Rajandra. The floor is yours, Doctor.
Okay, good afternoon. Thank you, Louis, for the introduction. And thank you, Dr. Witty, for the opportunity for me to share my knowledge or experience regarding the spine pain, back pain, basically. All right. Can we start the presentation? All right. So this is my topic for today. It is a back pain, young spine versus old spine. So we as a doctor, we have seen a lot of patients comes with a back pain. So we can basically divide the group into a young patient and old patient. Both of them, even though they have the similar complaint, but the pathology or the presentation is a bit different, and also the management also will be different. Okay, that's me, Rajandra Kumar Karupiah. I'm an orthopedic and spine surgeon currently in Taman Desa Medical Center. So before we start anything, we need to understand what's the definition of back pain. So when we talk about back pain, it means that it is a pain that originates at the lower lumbar region. Sometimes it can be also as presented as at the buttocks region, and occasionally at the thighs, which varies with the physical activities. So when we talk about the back pain, we also need to talk about the sciatica, which is a nerve root pain, a neuropathic pain. So when we talk about these two, we need to understand the neuropathic pain is different than the pain of the low back pain, which is usually is also elderly. Okay, when we talk about the young, usually it means 40 years and below, and about between 20 to 40 years old. Elderly usually about 50 and above. So in the young adult, the most common, we have a disc pathology, which you all know as a prolapsed intervertebral disc or PID. Then we also can have a trauma, which is cause fractures and also dislocation. We have the infections, mainly a pyogenic discitis or osteomyelitis of the vertebral body, and also a tuberculosis infection, which can cause the back pain. The next is the tumor. This tumor, basically in a young patient, is usually a primary tumor, which can be a bony tumor or a spinal cord tumor, which can be intradural or extradural tumor. Meanwhile, for elderly, when we talk about the tumor for elderly, is mainly what we are talking about is metastasis. So when we elderly patient, when we find something abnormality with the X-rays, we need to find out what it is from. Is it some other primary that we missed before? We need to investigate further. Next is the infections. Infection is pretty much still the same. Most common is between the pyogenic and tuberculosis, which is very difficult to differentiate unless we do a biopsy to differentiate both of these things. Next is also trauma. Instead of a fracture, compression fracture or burst fracture, the commonly is we will have osteoporotic fracture. So most of the osteoporotic fracture, if there's no neurological deficit, we can treat conservatively with just some cast or bracing. And then the final one is a degenerative condition. As we know, it is a spondylosis, spondylolisthesis, and a spinal stenosis. So today we'll talk about the disc and degenerative conditions. The disc is a PID and degenerative is mainly a spinal stenosis. Both of these practically having the same pathogenesis, which is originated from the disc, but the presentation and the sequelae is different. So when we talk about the pain, we need to be classify the patient as whether he's having acute pain or a chronic pain. So when we say acute pain, it usually is less than 12 weeks. Chronic pain, it's more than 12 weeks. So most of the patients that come with a degenerative condition usually present with a chronicity of more than 12 weeks. The PID, it is very varies. It can be patient presented as early as few weeks, less than 12 weeks is possible. So first topic I'll talk about is herniated nucleus pulposus or prolapsed intervertebral disc. This is a very common cause of low back pain and unilateral leg pain. So when you mention unilateral leg pain, this is where we call about the sciatica, the radiating pain from the buttock coming down the leg. This is a clinical diagnosis, which we actually does not need an MRI. We use the MRI only for when we need to do a surgery or we really want to make sure that how severe is the compression to the nerve root. The peak incidence at the 4th and 5th, like I say, it's below 40 years old. It is more predominantly in the male group, and the 95% of the involved area is at the L4, L5, and L5S1 level, which L5S1 becoming the most common level of problem. So we all know the disc consists of 3 structures. One is the annulus fibrosus, nucleus fibrosus, and cartilage and plates. Excuse me. So the function of the disc, it functions as a share the load distribution. So a common example that I would tell the patient is the disc is like a shock absorber of our body, like how the car will have a shock absorber. This is for our body where it will have to go through multiple compression and decompression due to our activity of daily living. So the disc have to go through a lot of stress during this process. So in annulus fibrosus is the outer ring of the cartilage. It is a multi-layered lamella, and it forms the tough outer portion, and it is the function as the stability of the disc. Then we talk about the nucleus pulposus, which is the center part, and is the function to maintain the height and resist the axial loading. So when you have the patient with PID, one of the most common complaint will be the sciatica or the radiculopathy. How does the patient develop the radiculopathy is the next question that we need to answer. So there are 3 theory has been proposed. One is a biochemical inflammation. Number 2 is vascular. Number 3 is mechanical compression. So nucleus pulposus itself is considered as a foreign body for our body. So whenever there is a protrusion or extrusion from the annulus fibrosus, the body will perceive the nucleus pulposus as a foreign body and will induce an inflammatory event. Meanwhile, mechanical compression will cause a direct compression towards the nerve root and will cause the pain. So when these two combine, the severity of the pain will increase and will have a very significant radiculopathy pain. When these two will combine, will cause edema surrounding the structure, and this will decrease the blood flow. That's where the vascular theory comes into place. The patient will have sort of a ischemia kind of pain. So when we talk about the PID, we need to talk about where does it commonly happen in the disc. There's 3 areas. There's a posterolateral, central, and lateral. The posterolateral is the most common area of the problem. Is because the posterior longitudinal ligament is weakest at this point. So the disc that protruded can penetrate out and cause the prolapse. So we talk about when we do MRI for the patient, the purpose of MRI, we also want to see what type of morphology of the disc. So this is where we divide the thing into number one, bulging. When you say a bulging, the disc architecture is pretty much just distorted slightly, where the annulus is still maintained and the nucleus does not goes beyond the annulus. So at this stage, patient will present to us mainly due to the symptoms of back pain rather than the sciatica at this stage. The next step of the thing is we call protrusion, when the disc material has been protruding out and there's already a tear in the annulus at this stage. At this stage, patient would already develop some sort of compression to the nerve root, so they will develop a sciatica. The next thing is the extrusion, where the disc material, annulus, nucleus pulposus, will break through the annulus and come in contact with the nerve root. So at this stage, the inflammatory reaction will take place and will cause a severe sciatica pain. And the sequestration is when the disc material detach from the parent disc material, and this causes the severe pain inflammatory reaction for the patient. So we talk about the clinical presentation of the patient. So history, patient will cause complaint of this worsening of back pain. Patient will present to us initially with back pain. So why does back pain happen? Number one is because of the disc bulge. Number two, due to the annular tear. When there is annular tear, patient will feel the pain at the back rather than the radiculopathy. So that will be the initial presentation of the patient. So later on, as the progress of the condition worsen, there's a nerve root compression and also inflammatory reaction happens. So patient will complain to us as a radiculopathy. There is the radiation from the back or buttock into the leg. They will describe it as a tingling sensation or electrical like stimulation down the leg. Some of the patient can also complain of numbness and also weakness of the specific muscle group. So we also will ask the patient, what are the triggering factor to make the pain worsen? Most of the patient will inform to us that the pain is worsened by coughing or straining during bowel movement. So this will give us a hint that this patient most likely presenting with a prolapsed intervertebral disc. And also at the early stage, the pain will be exacerbated in sitting position, because when patient is in standing position, the load of the body's load will go into the posterior compartment, which is the pedicles and also the facet joint. And then once the patient sits, the load will be transferred into the anterior compartment, which is your disc materials. So next is lumbar radiculopathy. So the most common will include L4, L5, and S1. It radiates along the path of the sciatic nerve. So because of this involvement of this nerve root, patient can present with a weakness and also a sensory impairment. So based on the history itself, without the physical examination, we can already have an idea where is the level of the involvement. If the patient complain of the pain mostly on the anterolateral part of the thigh to anterolateral part of the leg, we know it's most commonly is the L4 nerve root is affected. If the nerve, the sensation or the tingling sensation goes through from buttock goes to lateral part of thigh to lateral part of leg, then we know it is a L5. And if it's all posterior, then it's most likely is a S1 distribution. So next is when we do a clinical examination. The clinical examination that we see, first we'll see when the patient stand up, there will be loss of lordosis because of the muscle spasm. And also there will be a listing. Patient will be standing, looks to be tilted to one side. And when we make a palpation, there will be increased sensitivity on palpation at the sciatic notch. And one of the classical examination we do is a straight leg raising test, and it will positive only if the radiculopathy pain reproduced and it's not a back pain. Then next we'll finish with a neurological examination. These are the neurological examination. We examine for the nerve root of L1 till S1. These are the sensory, motor, and reflexes corresponding to the particular nerve root. This is what I meant by listing. If you can see, the patient is standing, he will be tilting to one side. So this is to reduce the compression of nerve root to that particular part. So when listing out, so the nerve root will be free and the patient will have a reduction in pain. This is SLR, we'll do the SLR with a straight leg. Usually we only do up to 60 degrees. Anything more than 60 degrees is not considered positive anymore. Investigation, like I said earlier, this is basically on clinical diagnosis. So, however, we still need to do a plain X-ray, which is a AP and lateral view. Why we want to do is to make sure that we don't miss out any other pathology other than disc pathology. We don't want to miss tumor or infection that affecting the vertebral body. At this time, we can see there's a listing, there's a loss of lordosis, and sometimes we can also appreciate a loss of disc height, particularly at the L4, L5, and L5S1. These two loss of disc height, we can visualize on the lateral view rather than the AP. Then we do an MRI when when we're already planning for surgery for this patient, or when there is a failed conservative treatment, or there's a significant neurological deficit, or there's a cauda equina syndrome for the patient. So these are the few examples of the X-rays that we can see. The lateral view, there is a loss of lordosis. The patient's spine is very straight at the lumbar region. And also at L4, L5, there is a reduction in this space. This AP view. So this is what I say, a listing can be appreciated. You can see the spine is tilting towards the right side here. So another X-ray, similar. You can see there's a loss of lordosis and reduction of this space. And also, there's a listing at the lower lumbar region. So this is the MRI of the lumbar sacral on the sagittal view. As you can see, the white colored disc, this if you can see my pointer arrow, okay, this is how the normal disc will look like. This is a T2 weighted imaging. You can see the disc is practically is a white color because it will contain a water, and then the black is your nucleus pulposus. This is a normal composition of the disc. However, when you look down, this is where there is a lot of degeneration or injury has happened, and there's also a disc protrusion area at this area. So it's L4, L5, and L5S1 area is affected for this patient. Another example, you can see there's a normal view. All right, this is an axial. You can see it is already compressing on the nerve root. There's another different patient. Very huge disc has been prolapsed out. This is already extruded disc. This is considered extruded disc. Okay, it's the same patient. Okay, so when we already have diagnosis of prolapsed intervertebral disc, how we manage the patient? Initially, we will start with all the patient with conservative treatment, because studies have shown the long-term results of between conservative and surgery is almost equal. So therefore, we always start with a conservative treatment, unless patient is in severe pain or there's a significant neurological deficit. So we treat the patient, we ask the patient to do a physiotherapy. The physiotherapy, in whatever treatment that we give the patient, physiotherapy will stay as one of the mainstay for this patient. Surgical, even after surgery, patients still need to do a physiotherapy regularly. So we give a physiotherapy and analgesia. Analgesia is based on the how severe is the pain. Sometimes if we'll give NSAIDs and also tramadol. And if this patient develop a sciatica, then we can also start the patient on neuropathic medication such as pregabalin and also gabapentin. If the conservative treatment fail or patient having a severe pain, then we can offer the patient for percutaneous procedure, such as a percutaneous laser disc decompression, radiofrequency nucleoplasty, radiofrequency annuloplasty, facet joint radiofrequency ablation, and dorsal root ganglion radiofrequency ablation. These are the few percutaneous procedures. If it fails or it's a very severe or huge disc, then we can offer a surgery, which we can do an open surgery or MIS, or now it's become very famous doing endoscopic surgery. So mainly what we're going to do, we're going to do a partial discectomy, where we only remove the disc that is already protruded out. So the main bulk of the disc still will be maintained inside. We only remove the loose and detached from the parental disc only. So these are the few postures that we will advise the patient during the physiotherapy. This is a back care posture. This is very important for all our patients to know this, so that they can prevent the recurrence of the condition. Okay, that is for the young patient. So when we talk about old patient, we talk about the degenerative lumbar spine disease as a big topic, and we can subdivide it into lumbar spondylosis, spondylolisthesis, and spinal stenosis. Lumbar spondylosis is basically patient presented with low back pain with no radiculopathy, and it's just due to the aging spine. Next is lumbar spondylolisthesis. It is a degenerative condition whereby one of the vertebral body subluxes anterior in relation to a lower part of the vertebral body. It's the most common in female over 40 years old and common at the L4, L5 level. Diagnosis is made with the clinically, we can feel the step deformity on palpation and further confirm with the radiology, plain X-ray, AP and lateral view. And in this patient group, we also asked to do a flexion and extension lateral view. This is to see whether there is some amount of instability or not. If there is an instability present in this kind of group, we will advise the patient for surgery to fuse the spine so that the pain and the radiculopathy will reduce. So MRI studies are very helpful for central or foraminal stenosis secondary to lumbar spondylolisthesis. So you can see the imaging, and there is a vertebral body of L4 has been migrated anteriorly compared to the L5. So next, this is spinal stenosis. We will have a lot of patients who comes to us with this kind of problem. It's a degenerative spinal condition characterized by narrowing of the lumbar spinal canal due to a variety of bony and soft tissue. The main diagnosis is, even though by clinical, but we confirm with an MRI study, mainly happen to the patient of more than 65 years old, slightly in males, and most common area is L4, L5 area. The risk factor, Caucasians, and if you have a patient with an obese patient or increased BMI, then we will be worried that it can worsen the condition also. Or sometimes we have a congenital spine deformity also can cause spinal stenosis. So how does the spinal stenosis happen? So like I said, PID related to disc, spinal stenosis, the main problem also related to disc. So what will happen, the disc, the normal disc, which is healthy disc, as we age, we will go through some degeneration, where the water and proteoglycan contents decrease. When this thing decreases, the height of the disc will also decrease. When its height of decrease, the entire construct of the spine will become loose. So the body will try to stabilize the thing by going through a process of hypertrophy of the facet and osteophyte formation at the facet joint to stabilize the spine. All these things, reduction of the disc space and also increase of the facet joint and also hypertrophy of the ligamentum flavum will cause the reduction in the canal size and therefore will cause the patient to have a spinal stenosis. Okay. This is how the normal healthy spinal canal will look like, the spinal cord and the canal. However, in the patient with the degenerative condition, because of this facet joint hypertrophy, disc bulging, and ligamentum flavum hypertrophy will cause the narrowing of the thing. Okay, now the clinical presentation of the patient. What are the main complaints the patient will complain? For lumbar spondylosis and spondylolisthesis is pretty much the same, where they only will complain of back pain. And mainly the back pain they will present to you is the worsening upon standing up from sitting position. This is different from the early prolapse intervertebral disc, whereas the pain is worsened on the sitting position. In this condition, why the patient develop pain upon standing is opposite of the PID, because this one, the load from the anterior compartment will transfer to the posterior element, which is your facet joint. So patient will have the back pain. So lumbar spinal stenosis, the presentation will have back pain, but the main complaint will be a radiculopathy pain and also a calf pain. Sometimes when we talk to the patient, they might not have a back pain, but the main significant complaint they will say is they feel their calf to become very heavy upon walking a certain distance. So in this kind of group, we need to take into account, is that a possibility of vascular claudication or neurogenic claudication in place? If there is a significant disturbance in this, so we have to be worried we don't treat wrongly in this patient. In vascular claudication, the distance will be almost similar when the claudication pain starts. But for neurogenic claudication caused by lumbar spinal stenosis, the pain varies. Sometimes they'll feel the pain after 50 meters, sometimes 100 meters. So it varies. And the patient will feel much comfortable in spinal stenosis to bend forward. So you can see when they're pushing the shopping cart, they will tend to bend forward to alleviate the pain. Also, in patient with spinal stenosis, when they have this pain, they need to sit down. So when they sit down, they will open up the foramen, so the blood flow will re-establish and patient will feel better, compared to the vascular claudication, where the patient just need to stop doing the activity and they will feel better already. So as the same as the PID, the nerve root involvement will follow typically the same L4, L5, and S1, as I said before. Investigation is a plain radiograph and also an MRI. Then how do we treat this patient? Same method of treatment. When for the patient with back pain, physiotherapy is still the mainstay of the treatment and analgesia. We want to strengthen the lower back and also abdominal muscle to able to compensate for the weight that is being transferred to the facet joint. Then we have the percutaneous procedure. We can use a PLDD, epidural steroid, facet joint steroid injection, radiofrequency injection, and when they do surgery, we can do a TLIF, transforaminal lumbar interbody fusion, or posterior lumbar interbody fusion, and also adjust a laminectomy if the patient does not have any instability. Okay. These are the few procedures that we do. When we do, the patient will be in a prone position. All right, we'll be doing it's like a surgical. We perform a surgery with clean and drape. This is how with the needles that we'll insert for the patient. All right. So the first, when we do a facet joint radio frequency, we will use a image intensifier as our guide. Okay, this is where we will be targeting the. As you can see, this is the facet joint. This is the pedicles of it. So when we're going to inject, we will inject at the lateral border of the pedicle. And once we already identify the area, we will do an oblique view to get a proper view. So when we do an oblique view, we need to be able to visualize this Scotty dog. You can see, these are the Scotty dogs that we usually set in the oblique view for us to be visualize the condition. So these are the components of the Scotty dogs, and you can see the ear is usually the facet joint, and the leg is also a facet joint. The eyes is the pedicle, and the neck is a parts, and it's a body. These are the component of the facet joint. This is how we do the injection. So the targeting, we will target to the eye of the Scotty dog. All right, we'll do a right and the left side. So this is for your facet joint radio frequency ablation. We will do a continuous ablation where we will be burn off the middle branch nerve so that it does not give any more sensory pain from the affected facet. Next thing is the PLDD. We do a lateral view. We will targeting to the, this is the needle, this is this space. We will targeting to the center of the disc. As you can see, we'll do AP and lateral. As we progress, we will always check to make sure that we are at the right level. So once we already sure that we are at the center on the lateral view and center on the AP view, then we can start on the laser decompression. This is for L4, L5, and this is for L5S1. Due to the presence of iliac crest, we will do a different kind of angulation for this. Okay, and this is where we do a dorsal root ganglion. And for dorsal root ganglion, we will use a pulse radio frequency ablation so that it will just work as to reduce the inflammation surrounding nerve rather than burn the nerve. So this in a spinal stenosis patient, where we do a dorsal root ganglion. So when we inject the dye, you can able to visualize the nerve root. So when we stimulate this area and we do a pulse radio frequency, we will able to reduce the inflammation and we reduce the pain for the patient. So you can see clearly the nerve root after the contrast injection. Also this, the contrast injection, you can see the nerve root. Also here. This is mainly for the degenerative patient, we can see it. And then for some of the patient that we might need to do a intradiscal injection. So when we insert a dye, you can see that there is a leaking going to the posterior part also at the anterior. So this means this is quite a damaged disc for this patient. All right. Thank you. That's all for my presentation.
Okay, thank you, Doctor. Okay, I have prepared a few questions.
Okay.
Okay, so the first question is, what primary care could offer to patient who come with a complaint of acute back pain?
Okay, when you say acute back pain, what the primary care can do is to provide immediate pain relief. So immediate pain relief would be giving adequate analgesia and adequate muscle relaxant. And then once for about a couple of days, then to refer them to a physiotherapist initially for muscle massage and also the transcutaneous electrical stimulation before we can proceed to the strengthening exercise. So the primary care function as to reduce the pain immediately. So that's why the pain medication comes into play.
Okay. Okay, this is my second question is, usually when someone have back pain, some doctor will advise to rest in bed, and some will advise to stay active. So which one should we follow?
Okay, we at the acute stage, then we need to advise the patient to some amount of activity limitation, but not complete rest in bed. At the same time, we cannot advise the patient to be active like in before the pain. So there is an adaptation period where we'll ask the patient, you can do almost everything, but reduce the intensity of it. Because if you're going to lie flat most of the time, then it will going to cause a muscle weakness, which going to contribute to further worsening of the pain. Okay, but remember, patients still cannot perform aggressive activity during this period.
Okay, all right. There's a question from the floor. Any red flags GPs has to watch out for back pain?
Okay, the main thing, the red flag that we need to watch out is to make sure that you don't miss out the infection or tumor, and also a significant neurological deficit in this patient. So when patient gave a history of loss of weight, loss of appetite, then this will give you a trigger point for you to think that we are maybe not dealing with just a simple PID. We might be dealing with a more malignant kind of thing, can be metastasis or primary tumor. But if also patient having the concurrent high-grade fever with prolonged fever, coughing, then it will trigger you to think, am I dealing with infection, perhaps, maybe tuberculosis. So the history is very important in this thing. So these are the red flags that we look for. If patient have any sort of weakness, then it is already a red flag for you to think that this is beyond primary care, that we might need to refer to get a better or faster treatment for the patient.
Okay, all right. At what point that a patient should be seriously consider a spinal surgery?
The consideration of the spinal surgery, like I tell my patient, is always depends on two factors. One, what the patient is feeling. So patient is one, the person is going through the pain. So the pain, how severe is the pain? That's number one. Number two is the how severe is the disc prolapse or MRI. And with these two combined, we still will always ask the patient to do physiotherapy for as initial phase, because the studies have shown there's few parameters that we look for success of any surgery, mainly a disc surgery. That the first parameters is your SLR is positive. Second parameter is a significant neurological deficit. Third parameter is a MRI finding correspond to the physical finding. And the fourth is a failed conservative. So failed conservative is one of the parameters that we considered for a success of surgery. Any 3 out of 4 will give you a success rate of 90% and above. So patient comes to see the primary care. One of the options that you can give, or you can start initial treatment with physiotherapy before referring to us, so that when the patient comes to us as a spine surgeon, we know that patient have failed one of the first treatment, which is a conservative, then we can offer the patient the surgical procedure in this kind of cases.
Can the disc bulk reversible?
No, it does not reverse, but then what will happen is the disc material getting the nutrients from the end plates, the cartilage end plates. So once the disc has protruded out, it will lose the nutrition support. After some prolonged time without nutrition support, the protruded disc will shrink and become smaller. But it does not mean that we be able to reverse it back to normal. No. Whatever has been comes out, it comes out. That's why I said at the beginning, the treatment of the patient with going through physiotherapy or conservative treatment and surgical patient, long-term outcome is more or less the same. It just the surgical outcome will give a much faster response for the patient in severe pain. That's the difference.
Right. And of course, actually, in a lot of social media channels, we do know that some of the chiropractors is actually offering treatment for back pain. So
Okay.
what is your view about that?
All right. I don't believe on the capability to push back the disc inside back again. I don't believe that is possible. Okay. But I've read and I've seen that what the chiropractic does is they will do some stretching and also reduce the muscle spasm. To my level of knowledge on chiropractic, that is what I can say at this point. But it is totally not possible for you to be able to push the disc back inside.
Okay. This is another question from the floor. What type of physiotherapy you would advise? I think you have answered that earlier.
Yeah.
Probably you need to answer. Yeah.
Okay. Physiotherapy that we can see is whatever McKenzie exercise actually. So basically, when we ask the patient for physiotherapy, it depends on the state of the patient. If patient in severe pain, then the physiotherapy will not proceed with the muscle strengthening exercise. So the main thing will be focused on reduce the muscle spasm, and then to increase the mobility of the spine. Then the third will only be focused on strengthening the muscle, mainly of the back muscle and also abdominal muscle to compensate for the load. So always reduction of the muscle spasm, spine mobility, and the third will only be your strengthening exercise. At the end of all physiotherapy session, the physiotherapist should reinforce the knowledge of all these three things and make sure the patient does the physiotherapy at home, and also patient practice a proper back care. That's very important. Some of the patient will not be able to go to the physiotherapist very frequently. So what they can do is they learn from the physiotherapist during the first few sessions of the strengthening exercise. They do it regularly at home, which is give a very good outcome.
Okay. So there's another question. So this is, I think, okay, I have a patient. I just transcribed the things. I have a patient complain of back pain after epidural block for painless labor. What are your thoughts? Is it a wrong technique? And this kind of case, I have seen many.
Actually, it is the epidural thing is not related to this kind of pain. It does not cause, the epidural injection will not cause a back pain, because if you can see the anatomy of it, we just use this as the thing, because when we do a epidural injection, it's coming from posterior. The only element that is behind is only our ligamentum flavum, and after that is already your thecal sac and also your spinal cord, and your disc and all the other materials are in front of it. So whatever the injection that comes in does not affect the stability, does not affect your disc, and it should not cause the back pain for this patient. The cause of the back pain for this kind of group, probably there is already underlying some sort of degeneration or some sort of disc pathology is already been there. But then they try to relate the pain after the delivery to the latest incident that happened to the spine. So they always say that epidural is the one that causing the pain, but it does not do that.
Okay. So this is the misconception.
Yes, this is exactly a misconception.
Yeah. Doctor, what is your view about what are the what is the lead cause of back pain nowadays?
The lead cause of back pain, I would definitely say, is a poor back care among our society. You can see very clearly the way that we sit, the way we sleep, or the way that we get up from the sleep. We carry all these things. These are all a small thing which accumulative to the spine. So that's why we'll have the back pain. So the main cause will always be the poor back care. That's where our physiotherapists, with the proper back care education, we will able to reduce the pain very much.
Understood. Okay, I don't see any more question from the floor. So I think we shall wait for 30 seconds, perhaps. See whether any problem from the floor. So at the meantime, just have a chat with you, doctor.
Sure.
So it is very it's sad to say that nowadays actually many youngsters are start to having back pain. You know, as compared to probably 15 years ago, and not that many. Right? What do you think the cause? I mean, the youngsters nowadays, everything is getting younger and younger, and in all the diseases.
All right. They can be multifactorial in these things. One of the things I would say that the back care, the proper back care things. Number two is the involvement of heavy activity. I mean, strenuous activity, like they are going more into extreme. So jumping up and all this bungee jumping and all these things. So this kind of groups of people will have more strain or stress to the spine. Okay. And then the third is also will be about, I'm not generalizing, but also
Mm.
in the way the people or the younger generation has been brought up compared to the elder generation. It basically is a psychological part of it. It's going to be there.
Okay, I don't think any more question. I think we're going to end it. Doctor, you wanna say a few words to our participants? We have 100 or almost 200 participants.
Okay.
And these are out of doctors, yeah.
Okay, the main thing I would say that the initial back care management is under the general practitioner or primary healthcare provider. So they can reduce the severity of the case that comes with the proper management, with the analgesia and proper referrals. And number two is, if you have any case, don't hesitate to refer to me for a better, for any of, okay.
Doctor, there's one question. Just
Yep.
what about back? What about back massage chair? And nowadays, youngsters are glued to handphone, causing back pains.
Okay, the massage chair, like I said, what massage in generally what it does, it just to increase the blood flow towards that particular part of the muscle. So when there's increased blood flow during massage, so it will take out the toxic material that causing the pain away, and also will be able to reduce the pain. At the same time, it also can able to reduce the spasm. So the massage in general, massage chair in particular should be providing the same amount of effect. Right? And when using the phone, this is one of the cause of pain, of neck pain, when they will always tend to look down, and then eventually the neck muscle will have to counter the weight of our head during the process. So the phone will cause neck pain, and massage chair, it should be some, to a certain extent, improve the blood flow towards that particular group of muscles to reduce the pain.
So we actually foresee that the next generation will have more,
yes,
neck pain issues.
Actually, we already seeing the increased number of patients in that group of to present to the clinics with the complaint of neck pain.
It's very sad. This generation, we are facing so many viruses attack, so many mechanical injuries.
Exactly.
All right. Okay, I think that's all for today. There's no more question. Thanks for having you, Doctor. Thanks for agreeing joining us today.
Thank you for inviting me.
Yeah, thanks for Doc Quitty as well. So I think nothing much. Then we say bye-bye to everybody.
All right. Thank you.
Thank you. Bye.
All right. Bye.